I will now request the esteemed speaker for this oration, Professor Chintamani, Professor Head Department of General Surgery, VMMC Safdarjung Hospital, New Delhi. An excellent teacher and a surgeon of repute. We welcome you, sir. I will request the chairpersons to please introduce the speaker.
It's a great honor to introduce the teacher of teachers, Professor Chintamani, and the oration, of course, in the loving memory of Dr. Neogi, father of one of my colleagues and senior surgeon in our department at Medical College. Professor Chintamani is a very well-known figure. It doesn't need an exhaustive introduction. Very well-known national and international surgeon. Is governor in the Association of American College of Surgeons, and also a very important figure in the Royal College of Surgeons, England. And we are privileged to have him here and listen to him speaking on about thyroid surgery. So without wasting time, since he has to go back the same evening, and really he must be getting, jittery to catch the flight. So sir, it's over to you on thyroid surgery.
Thank you very much, Chairperson, sir. Good afternoon, ladies and gentlemen. At the very outset, I would like to thank the IMA for this honor, and especially since a very dear colleague and a friend, Dr. Prof. Neogi, is here. It's truly a joy, Dr. Prof, to be speaking in the memory of somebody as exceptional and as illustrious as your father. Now, ladies and gentlemen, when you talk about a surgeon's approach to thyroid, it could have a little bit of a bias in that you would like to take everything out. But believe you me, I'll try to make it as rational as possible. Thank you. I'm sorry about that goof up. So, the title is When to Pick Knife in Thyroid Swelling. Well, by and large, most thyroid disorders would be initially treated medically, but they end up in surgery. The reason is very simple. It essentially is a surgical problem, except for very, very few situations. So I'll be addressing the issue as the surgeon looks at it. Is there something is running? Wondering. No, that's all. So when we talk about thyroid disorders, what are we actually referring to? Is it one such entity, or there is a heterogeneous group of conditions, or is it something that can be spoken of as one entity? The answer is no. When it comes to talking about cancers, there is no confusion. The answer is surgery. When it comes to talking about keloid nodules, there is usually a confusion in about 15 to 20% cases, otherwise it's all surgery. If it comes to toxic situations, barring a situation which is classical thyrotoxicosis without any lump, and we know those conditions, I'll be talking about them. So there will be very few situations when you would be actually needing knife. I would prefer to call that a scalpel, because knife can mean many things. But knife in the hands of a surgeon is essentially a scalpel. So when do you do it, and how much do you do, and how much is optimal? These are the three aspects that I'll hopefully be able to address by the time I finish. The usual presentation of thyroid, shall I say, disorders, is in the form of a solitary thyroid nodule, which is pretty common, or a thought to be solitary thyroid nodule but a multinodular goiter, or it could be surprises. That is, you've done an ultrasound for something else and you pick up those incidentalomas. And these are causing a lot of problems these days, and that's where the decision making can be a challenge. What is a solitary thyroid nodule? I'm conscious of the fact that I may have to revise it for the sake of my very good friends who are practicing as general practitioners, or those who are physicians, because they supply us with the patients who would require surgery. So a lot of time, they're the ones who see them first. So a palpable nodule in an otherwise non-palpable gland, because remember, there is no thyroid gland which is palpable and it is normal. Any palpable gland is diseased, by and large, barring the physiological goiters, which again, if they last for a while, they will become pathological. They're approximately 4 to 9%, and at the bottom line, you can read it, only 38% of what we perceive as clinically solitary thyroid nodules, once we subject them to ultrasound, they're solitary. Most are benign, and if it's an adequately trained surgeon who is effective, safe, and well informed, surgery is a great option, leaves minimal morbidity, and actually it's not as bad as you feel. But surgeon is a risk factor. If he's not good enough, and if he hasn't done enough, it's much better to leave it alone. This classification is obsolete now. I've deliberately included this slide to make it obvious to everyone. We no longer do this classification into warm, cold, hot nodule. One, it is very cumbersome. Two, it misses out many malignancies. And three, it exposes the patient to unnecessary activity. So, for those who are very keen on knowing about it, generally malignancies are not toxic. The reason is cancers don't secrete. So by and large, if a patient has got thyrotoxicosis, he doesn't have cancer. But in 10% cases, you may have cancers that do secrete. So it can still be hot. Cold is dicey. It can be a cyst, innocuous nodule, but it is quite likely to be cancer. As you can see, the percentage would be 14 to 22%. And warm is in the middle, and usually it's the worst kind because you miss out on either side. That's one reason why it has been given up, and we don't use this classification anymore. Failed medical treatment. Initially, there is a tendency to put these patients on therapy. So basically getting treated for Graves, but then there is a goiter that appeared, and as the goiter appears, you are not in the right plane. You should hand it over to somebody who will get the disease gland out. And especially with the ophthalmoplegia, surgery gives better results. Another case, a young gentleman who's actually a jeweler, and he needs his concentration, and his blackouts were too frequent. He was on medical therapy, had to be referred and taken up for surgery. The problem with surgery is surgery itself. That is, you may cause morbidity, you may cause rarely mortality because you're intervening. But the advantage, if you can do it properly, is you're getting the disease out. And then there is nothing like recurrence of thyrotoxicosis or coming back of cancer, etc. You can see that as a classical absence of wrinkles, Geoffroy's sign as you call it. And he had this nodule building up while he was on suppressive therapy for a while, which is something MNGs are classically, as I described, they can be presenting in various forms, including retrosternal extensions. You can see this is the part which was going into the anterior mediastinum, and there's no confusion about surgery here. Similarly, you can see the dilated veins here. I'll just go through some of the pictures to just highlight a point that I'm trying to make. There's no rocket science here that this patient has got retrosternal extension, superior vena cava syndrome features, needs surgery. There's no time, no reason to waste time on. There's absolutely no logic in wasting it. And you take up the patient for surgery, you cure the patient of the problem. A classical butterfly kind of an appearance, where this is a typical endemic goiter, you get to see a lot of them. They carry it for a long, long time, Now what's the problem with that? There are only two major problems. One is relating to it becoming a cancer or it getting toxic. In both situations, it can be a morbidity which you could have easily avoided if you're treated in time. Another one, getting treated for a solitary thyroid nodule on a medical suppressive therapy comes up with a node in the posterior triangle, that is level 5, and on good ultrasound guided FNA was papillary, and that's what you need to be extremely careful about. Well, this is how they look, so I'll leave that part. But more importantly, when not to pick up a knife, because this is very, very important. A good surgeon is the one who knows when to actually operate. A better one knows how to operate, and the best one knows when not to operate. You need to know when I shouldn't put my foot into it. Uncontrolled severe hyperthyroidism, classical Graves' disease, where the first line therapy is medical, including radioactive iodine. However, the moment a nodule appears, this patient shifts towards surgery. Pregnancy is safe enough, and we do operate second trimester very comfortably without any trouble, but you can always wait. Most of these cancers, if they happen, are very slow growing. Most of the problems, if they are controlled medically, they can be later on taken care of. Safest time is second trimester, especially when they are aggressive cancers or there's an airway compromise. Otherwise, you don't need to operate. Anaplastic carcinomas, you will not be able to operate, so it's safer to believe that it's not good to operate. Because when you go in, you won't be able to remove much. But yes, that doesn't mean you won't do surgery of any kind. You need to clear off the pretracheal space for patient to breathe. This is anaplastic carcinoma, but you can see an old scar of previous surgery. The trachea is pushed. This is not a case for surgery. It's actually, this patient is not even fit for a haircut. So you cannot be taking this patient up for any intervention. It's too late in the day. But this usually happens because of the delay in the therapy that continues to happen. Central compartment nodes in a cancer inadequately treated. You can see that they are fungated through. And this is fatalistic approach that we observe so commonly in this part of the world. We get lots of referred cases, and we do see this at our center. Sadly, they often keep getting some kind of an advice. I won't mention here, but he was on some kind of a non-conventional therapy, and that is what led to its fungation. There are certain clear indications, then there are gray zones, and there are contraindications. I already talked about where you don't do surgery. Now let's talk about where we actually pick up knife, and we do so happily. Malignancies, except anaplastic carcinomas. Differentiated thyroid cancers, DTC stands for differentiated thyroid cancers, which is the majority of cancers in thyroid. Medullary cancer is not a true thyroid cancer at all. It comes from parafollicular C cells, which simply lie on the posterior surface of the gland. Therefore, we have no choice but to remove it. The gland comes out because the medullary would involve the gland. And wherever you get medullary carcinoma of thyroid, there's no other treatment available. You chase it with knife. There's no question of any medical therapy at all. Any symptomatic goiter, symptomatic in the sense that I just mentioned, airway problems, or there are features of the vocal cord or the trachea or the recurrent laryngeal getting involved, or a patient has retrosternal extension, or it's so bulky, or there is a secondary toxicosis. Of course, cancer I've already mentioned. The American Thyroid Association guidelines say any nodule more than 3 centimeters. Some of them say 4, so I put 3/4. And this is ultrasound measurement. No longer is the clinical measurement valid in today's scenario. In fact, clinical examination of thyroid is considered incomplete unless you've done an ultrasound along with it. So these are the guidelines to operate on these cases. If the diagnosis is equivocal after triple assessment, what is triple assessment? I'll address it. All endemic goiters are prone to developing thyrotoxicosis and follicular cancer. So we should not leave them alone. And this is, you know that, it's popular, it's common in the South Himalayan belt. Incidentalomas, friends, are these days with the corporate checkups happening more frequently. The patients go for a routine ultrasound, and in the process they buy a little incidentaloma, which is called microcarcinoma or a micro lesion. And then ultrasound guided FNA starts off a spinning wheel, and the patient wants to be diagnosed till the cows come home, FNA and what have you. And eventually, it's a sitting time bomb. Most of them don't translate into becoming invasive cancers. They don't kill, so they can be observed. There are debates over this, and in all our thyroid meetings, there is a group that says we should take all of them out, and there's a group that says we should have a close surveillance, and wherever you don't have a close surveillance, it's safer to get the whole thing out. Cost basis is a very important factor, and if the patient desires and feels very strongly about it, that again is a symptomatic goiter in some way, because the patient is conscious of this appearing in front of the neck, indication for surgery. No confusion here, elderly lady with a solitary thyroid nodule, but please don't miss the node here. This is a papillary carcinoma, would require total thyroidectomy with neck dissection. No confusion here, it's a straightforward surgery, and there is nothing else that works here. This is a papillary carcinoma of thyroid. Medullary, I've already told you. Goiters like these, you still see them in this part of the world. You can see that some out of the external applications have been tried, which have caused changes in the skin, and we realized that this was so intense that it reflected onto the nodules inside as well. Retrosternal extension, like you can see the Pemberton sign being positive, which you can do in your clinics. I've deliberately included this. Goiter not looking so big, but lower down in the neck. Do this test, and you can see the face is flushy. Or if the patient is fair, you can actually see the congestion clearly. If you don't see it, if the patient is dark skinned, you can look for the conjunctival congestion. Like here, it's so grossly and obviously visible. Would require surgery, although it's a very small nodule. Rarely you run into these kind of cases. You can see an old scar here, and there was some kind of a thyroidectomy done some years ago. Patient had a weeping wound for a long time and came with a little bit of a swelling, nodule kind of a thing here, and a discharging ulcer. Edge biopsy from the ulcer, not the FNA. Edge biopsy showed it to be squamous cell carcinoma, which is very, very rare. In fact, we had reported there are 84 cases reported, because it's very difficult to make out that this is not from somewhere where the squamous lining is there. So you've got to exclude all the cancers of aerodigestive tract before you call it the primary thyroid squamous carcinoma. Needs surgery, very aggressive, kills patient in a year, and needed complete removal. You can see the recurrent of left side, right side, parathyroids here, and central compartment is all cleared out. And basically, this needed aggressive surgery. You can see the recurrent angioma again, level 2, 3, 4 lymph nodes, that's trachea, and that's a recurrent angioma parathyroids. So needed surgery. Just to highlight it, I thought this would interest you. External angioma, sentinel pad of fat to identify parathyroids. That's how you identify parathyroids. Most people ask this question in the exam, MBBS time, also in your medicine or surgery postgraduate examination. How do you recognize parathyroids? Well, there's an old Sebastian book, if you read surgery book. It says, it looks like the tongue of a jaundiced hummingbird. Mrs. Neogi is here. She's a David wildlife photographer, so she would appreciate it. Hummingbird is a thumb-sized bird where the sound comes with flutter wings. So you would rarely sight it. Then you wait for it to get jaundiced. You expect it to stick out its tongue and then look at the color. So that was a polite way to say in the past that forget it, you will never see it. So what they would do is subtotal thyroidectomy, something which is obsolete now. Nobody does subtotals anymore. And if you hear of it, please condemn it. Say that it's an inadequate surgery. They were doing it because they believed, don't see, you will damage it. So it was believed, seen as damaged. While now the concept is not seen as damaged. So we need to see and show. We in fact have to show it to our assistants, to the anesthetist especially, would be very keen, and then we get out of it. So basically golden yellow in color, and this is a probe test that I call. When you get close to the gland, it starts getting congested, which I tell my residents, it's getting angry and it's trying to tell you, you goofy, you don't realize I'm parathyroid. I'm not fat, for God's sake. That's sentinel pad of fat. That is, sentinel means a guard. So it guides you to the parathyroid. So that was a little story with that. So we closed it. So is an aggressive approach justified in the management of an aggressive cancer when it happens in thyroid? Otherwise, ladies and gentlemen, thyroid cancer, we talk about 20 years survival. We don't talk of 5 years survival. It's a very good cancer if you want to wish someone. It's a sad thing to do, don't do it. But if at all one has to, this could be the getaway, because they live for 20-25 years comfortably. But there are rare cancers of thyroid which can be aggressive. Another example, the first I showed you, this is the second primary squamous cell carcinoma. You can see the scar of old surgery, inadequately done, some bit of goiter remaining. Patients come back with a stoma in the trachea, which means what? There is an airway compromise, which means what? It is infiltrated into the airway, which means what? We have left it behind and it has come back with vengeance. So they may look innocuous. This justifies surgery for most nodules which are more than 3 to 4 centimeters, the ATA guidelines. So there's no point sitting on it with suppressive therapy with the thyroid. It's not a great idea. And especially as general practitioners, if somebody is to refer, or a medical, or an endocrinologist. We have an MDT with the endocrinologist and the medical oncologist and all. And in that MDT, we ask them to speak, and a lot of them agree that suppressive therapy has to stop at one point. It doesn't work very well. And no, it doesn't serve as a diagnostic or a therapeutic trial, another important thing. Now, what we had to do here was, therefore, total thyroidectomy along with laryngectomy, which you see now, the larynx being removed. That's the left-sided internal jugular vein, common carotid. So we do bilateral neck dissection with preservation of internal jugular vein on one side. We need to preserve on one side. And you can see the nasogastric tube or the Ryle's tube. We have removed the anterior wall of the pharynx because it was stuck there. Actually, for this patient, there is no other treatment. So is there any other option? The answer is no. If it is medullary, again, we would have no choice. So everything gets removed, including the skin, and it's reconstructed using a deltopectoral flap, which is easily done. But the tragedy is he will live with a tracheostomy for all his life and with the nasogastric tube, and later on, of course, we'll have other ways of feeding him. But between life and quality of life, you need to first choose life. You cannot have a good or a bad quality of life if you're not living. So therefore, it's necessary to refer in time. They need a very specialized treatment. There should be no jiggery-pokery with a nodule or a thyroid swelling. We shouldn't drag it for too long. That is what was the message I wanted to convey. Another one, and this lady. She has been carrying this for a long, long time, a tribal lady. And you can see dilated veins. She was hardly able to breathe. And in this case, we need a CT scan to see whether there is a retrosternal extension. There is. And she needed an emergency surgery, similarly here. So the relative indication would be, when in doubt, take it out. This is a very old surgical dictum, because if you are in doubt, you can't let the patient pay for it. You can clarify, counsel the patient, and you can go ahead and do the needful. Missed diagnosis, and you cannot be putting the patient on suppressive therapy for long. Another case, which probably if time permits, I'll show you a little, really short clip of it. That's a nodule and that's a lymph node. It was actually papillary. Very commonly you observe that. Certain clinical factors, ladies and gentlemen, which mandate early surgery without confusion, and it doesn't need rocket science. You don't need triple assessment here. You will be doing wherever possible, but refer it as you can. Age, nodule developing in young and old patients. It's believed to be 55 years cutoff, less than 20 years. Male gender. Look, women get it more often, thyroid swellings or papillary. But when men get it, it's a worse prognosis. Nobody knows why. 45 years was the cutoff earlier for the gentlemen, and for ladies it was 50 years, they were safe. Now, nodules occurring in patients with Graves' disease, I've repeated, or Hashimoto's thyroiditis. I've operated on lots of Hashimoto's thyroiditis after they've been treated for a long time medically. And sadly, when they come, they've already got a diffuse gland where they may have hypo or hyperthyroidism. It doesn't matter, depends on how active the gland is. But importantly, papillary carcinoma or sometimes Hodgkin's could be lurking in there. So nowadays, surgery is recommended. Previous radiation to cervical region is a high risk factor, leads to papillary cancers. if it has been done in the childhood. Now earlier there was therapy given to children for various medical disorders like adenoid hypertrophy, acne, and what have you. There are many. So with that low dose, it was considered that it could trigger off oncogenesis. And it was believed that high dose was not causing it because it is ablative. But today we know that even high dose can do so. Now where do they get low dose now? Because when you're treating for cancer, you'll give optimum dose. There's nothing like low dose radiation. CT scans in pediatric age group. Now there's an ATA paper on this, that each CT scan done, because especially in US, the first line investigation, first line imaging in many conditions, including appendicitis, is CT scan, which is not a safe modality. That's what the paper was referring to. And this is an exposure. Chernobyl accident, which we all remember, and of course Hiroshima, and those survivors had pulmonary cancers and we found it. Pain, compressive or infiltrative features, and invasive features include hoarseness of voice. The patient says, my voice has changed, my voice has become more hoarse, and it's persistently worsening, then it should scare the hell out of you. But just sore throat doesn't make it bad each time, because sometimes it gets corrected. So worsening voice. Of course, lymph nodes in the cervical region, and growth despite suppression is a case. A typical case, a 30-year lady from Almora, that is high altitude, ultraviolet exposure. 3 into 4 centimeters solitary thyroid nodule on the right side to the last 3 years. No features of hypo or hypothyroidism. No features suggestive of malignancy, firm non-tender, no cervical nodes. Where does this patient go? We had this case for MDT discussion in a conference. So we had a virtual MDT. Very anxious and super keen on surgery. What do we do? Now, should she be under the knife? Not straight away. Must be investigated, must be counseled. It can be observed. Patient doesn't need surgery all the time. But you need a patient who's understanding it. If the patient is anxious about it, maybe your decision may change. So therefore, how do you work up for a goiter? Triple assessment is the standard of care, ladies and gentlemen, today. There's nothing like you send the patient for FNAC, sometimes you send the patient for something else. And triple assessment is very standardized. If you go off the track, you can be asked as to why you did not do it. So even for a legal purpose, please understand, the answer is triple assessment and rarely quadruple assessment if it's a cancer, because there you may do a panel, which is not required, especially in this part of the world. Thorough history and clinical examination. It will never go away from any scenario. You heard about diabetes or you heard about other conditions you'll hear. You need that history to be extremely thorough, including a very good family history. High resolution ultrasound, which means high resolution ultrasound. It is not just the ultrasound. High resolution ultrasound will pick up more than 10% more lesions than a routine ultrasound in the hands of a top-notch neck ultrasonologist. If there is a journal sonologist, he may also miss it. And we have TIRADs, like we have BIRADs. We have PIRADs for prostate, BIRADs for breast, LIRADs for liver. We have TIRADs for thyroid, which is the grading so that you can actually grade it optimally and objectively. And before you subject the patient to FNAC, you must have a thyroid function test done. It's mandatory. And it is in this order that you should proceed. It's not that you can do it wherever, whichever way you like. That's the algorithm. Why the thyroid function test is mandatory. If you put a needle in a toxic gland, you can precipitate thyroid storm. I've seen it, so I can swear by it. The other problem is, you can actually give false positive reports in the FNAC. How? Because it will be actually, you can get false positive reports because you get atypia and you can get good about 10% false positives, and you can over-detect cancers. You can upstage the problem. So therefore, always have a euthyroid patient when you put in a needle. Today's era, today's day and age, the standard of care is all needles should go under image guidance. If they go without image guidance, it's considered inadequate practice. And quadruple assessment is when you add the gene panel to it, which helps you in prognosticating cancers. Not really necessary and not relevant here. What is high risk history if I have to look at it? Age, young and old. Middle age is fine. Very young, in any case in cancer, in oncology, remember, it is believed now, the theory of oncogenesis is that the change of the dysgenesis has started in utero. And the time it takes to show up is the aggressiveness of the tumor. Therefore, cancers of any kind that happen in younger age are more aggressive because they grew that fast and showed up. And the cancers that are at 80, 70, they're considered, especially say in breast, in thyroid and other cancers, they are less aggressive. So it's an independent predictor of disease specific. I mean, of course, today's classification of thyroid cancers, the staging is age-based. So you have a different stage for the same size, 55 and above, and below that. Earlier it used to be 45. The malignancy rate for nodules in childhood and adolescence is about twofold higher. And of course, now the cutoff is 55. High risk history when you're taking gender, male, they are likely to be taken very more carefully. Duration and progression, needless to say, radiation exposure, I've already discussed that. Compressive features would indicate a strong history. And what is a strong and high risk family history? All these syndromes. So it's no longer enough to say there's no family history of thyroid disorders. They're all controlled by your battery, if you could connect, please. Now, what do you do in imaging? So clinical history, examination, done. Now you come to imaging. High resolution ultrasound imaging is what is mandatory. I can never get tired of repeating it because ultrasounds, for the sake of doing them, can sometimes give misleading results and reassurance or assurance of a wrong kind. And it improves the diagnostic accuracy, needless to say, and helps in putting in the needle and getting an FNAC with a good yield. Scoring can be done, and basically contrast and CT scan, especially with contrast, which is iodinated, is not very popular for thyroid disorders because it's rich in iodine already. So non-contrast CTs or MRIs are preferred. FDG PET. Now I wanted to put it here, especially in this part of the world. In our clinics, a lot of patients walk in with a PET in their hand because somebody has got it done somewhere. PET is a useless test to do here. In fact, it's harmful because it'll pick up small inflammatory lesions like tuberculosis, so common in this part of the world. There's an article of mine, if you're interested you can read it. Can you bet on PET? Especially in this part of the world, it will upstage the disease when you don't need it to be doing it. So PET should be very carefully done in these cases. Now, whether this is how you divide it, I don't think that will interest you. If it does, then benign with very low suspicion, and at the other end are high suspicion, where malignancy risk is 70 to 90%, and you can see these are the conditions which I've partly described. And of course, benign is benign, you don't worry about it. If you get that report, you're happy, and you can tell the patient, we can review it after 6 months, provided you don't take any suppressive therapy, because that can goof up your picture. Low suspicion, partially cystic nodules, and cyst with solid. Remember, any mixed IC1, and if there is a solid and cystic component, you always put the needle into solid component, because cystic component is usually degenerated material. And if it is hemorrhagic cyst, a lot of people, once they aspirate hemorrhage, they do it second time. If twice it's hemorrhagic and on aspiration it is hemorrhagic, we label it as surgical case. You should excise it. And high risk are very obvious. And intermediate risk, solid, hypoechoic nodules with smooth margins, and then when the margins get irregular and there are microcalcifications, increased vascularity, extranodal spread, etc., taller than wide lesions. And these are the features which I've already highlighted. These are the features which will indicate it is malignancy. And this is how you do it. Safe, non-invasive, easily available. Today it's called the stethoscope of a surgeon. Every surgeon does his ultrasounds today himself. We do it ourselves for breast, for thyroid, because you know what you're looking for. It can be very focused and you can actually get the results you're wanting. This is the grading as it happens, from benign to high suspicion to actually the malignant one. And you can look at the taller than wide picture here. You can look at the extranodal extension, etc. Similarly, the lymph nodes. How would you know a lymph node anywhere in the body is suspicious? Usually the lymph nodes are bean-shaped. Like you heard, kidney is bean-shaped. Then you're asked, what is bean like? They say kidney-shaped. And what are they each other? They look like each other. So essentially, oblong is the lymph node. When it becomes spheroidal, we are worried because there is central necrosis, it expands. The vascularity increases, that's a risk. There is a loss of a halo around it, we call it the halo sign. That feature is gone out of the, this is applicable to all lymph nodes anywhere in the body. Now, that's Bethesda system for reporting thyroid malignancies. Today, if you send an FNAC from your patient's thyroid gland, this is how the report would come. And you should be familiar with what is Bethesda system. You have non-diagnostic, that means you've not done it properly, you'll have to repeat. And the risk is 1 to 4%, that is. Benign is 0 to 3, and of course malignant, it can pick up. Today, even without ultrasound, our sonologist is able to tell you in 80 out of 100 cases, we are just about to publish that data. It is malignant. It's such a useful modality. And hats off to the radiologists who have mastered it. And now we have a system of elastography which makes it even better. This is what I'll probably skip that. Now, I mean, that's what I was referring to, the false positive rate of FNAC. It's operator dependent, we all know. Negative FNAC has no meaning. Therefore, in most places, we have replaced it with core needle biopsy because a negative FNAC could be due to a subjective difference in how the person who did it and the person who analyzed it. So important to understand that. These are the limitations. A negative FNAC doesn't carry any significance, and amount of suction applied, etc. would matter. You can improve the FNAC report, or you can make FNAC more sensitive. Now, I am trying to kind of bring in physician, general practitioner, and surgeon into it, because the surgeon invariably come here because I'm here. What I'm trying to do is, the cytopathology can get better if you add immunohistochemistry or Ploidy studies or molecular markers or RT-PCR or mRNA and thyrotropin receptor mRNA in this case. This is what it does to the sensitivity if you add these panels. We studied this, and in fact the credit goes to these two gentlemen from IMA. We get lots of referred cases from the IMA for thyroid surgery. Most of them are cancers. So we studied that. We all been taught in undergraduate days, follicular adenoma and carcinoma you cannot differentiate based on FNAC because it has to breach the capsule to be declared cancer. It has to get into the vessel or the lymphatics to be declared a cancer. So lymphovascular invasion or capsular invasion has to be established, which cannot be done on FNAC. So most follicular adenomas, we treat them as likely to be cancers. Of course, that confusion is gone, but if you add this microfollicular basement membrane, then absence of it, then that can help. But the important thing, this is way back in 2003, no point mentioning this article. Today it's a standard of care. You add ultrasound to your FNA and your yield improves by 10 to 15%. So it's now a mandatory practice. We started it with high risk cases, and then gradually it is done in all. Now what do you do once you've done the FNAC? You will either decide whether the patient goes for surgery. You can do thyroglobulin levels, I'm not getting there. Calcitonin if you have a history to suggest it, but a routine calcitonin and a routine thyroglobulin level is not recommended. It's not a part of the standard of care. A word about radioisotope imaging. It has a limited role in today's diagnostic world. So where do you actually do it? One, toxic glands, especially if it's an adenoma, and you want to see whether the rest of the gland is active or not, and can you just confine your surgery to one site? Again, not really very strongly an issue anymore. With the kind of imaging that we have, we can focus our surgery into hemithyroidectomy totally easily. There are limited indications, of course, in diagnosis, but tremendous amount of role after surgery in management of cancer. Once you've done total thyroidectomy, you would like to know whether total thyroidectomy is total. And that you can only know once you've done an imaging after 6 weeks. Because if you don't do imaging, you would not know whether you remove the entire gland. And there's nothing like a true capsule in the thyroid gland. This is just by the way. There's nothing like an R0 resection if the surgeons are here, which means you've got no microscopic disease left behind, which we do with pathology, with the pathologist in most cancers. But here, we can't just do it because there's no true capsule. So what do you use for knowing it's R0? We do the scan. And if the pickup rate is less than 3%, we take it as a good enough job. And the other thing is, if you know after surgery there is some remnant disease, you can treat it with radioactive iodine. Thallium scan, well, it's of interest to especially nuclear medicine specialists. It can actually help you when you're having a what is this? Can you just, sorry, there was a Zoom link confusion. Now the risk of malignancy for low uptake are 0, 6%, 55%. So I'll skip that part. What is it? Okay, fine. I have it. If you're doing a CT, we don't use the contrast. I've already mentioned that. But we do CT in recurrent remnant disease, retrosternal extension. We do a CT to see the extent of retrosternal extension. We do a CT if there is an involvement of the recurrent nerve, trachea, and the surrounding structures. So, if I can say in T4 disease, or where you want to find out whether it's resectable or not. But iodine-based contrast might delay nuclear scintigraphy for 4 to 8 weeks, so we have got to be careful about it. MRI is only for soft tissue extraglandular extension. Very useful test. There is no disturbance with the nuclear scintigraphy, and we do it very frequently. And PET scan, since I mentioned, we do it for medullary carcinoma of thyroid. We do RET for some and PET for all. RET proto-oncogene study for medullary. PET we do for all because you cannot do radioactive iodine anything. This tumor is not thyroid cancer. It has no thyroid element, so it won't take up radioactive iodine. That is why that's the only place we'll use that. Well, typical case that I referred to, that we did surgery. How much is optimum is the last part of the presentation. Well, little surgical, but I hope it'll be useful. Today there's nothing like a subtotal thyroidectomy, so friends, if you hear of it, you should say that no, it's either hemithyroidectomy, which means one lobe plus isthmus, or total thyroidectomy, both sides plus the isthmus. Isthmectomy, lobectomy, partial thyroidectomy, these terms are all gone. We've all heard it. We've all done it also, but no longer relevant. So what is near total thyroidectomy? You attempted total, but you couldn't achieve it in the scan. That's near total. What is Hartley downhill procedure? You're doing surgery for thyroid. You start on one side. You're not able to see the recurrent laryngeal nerve, parathyroids. You can't take a morbidity. So on the other side, you leave a sheath of tissue on the contralateral, recurrent and parathyroid. So it's a deliberate attempt to leave behind a sheath of tissue. That's called Hartley-Dunhill procedure. That's hemithyroidectomy. What we do is taken out a lobe, that's the isthmus, and I take out a part of the other side, which is a protocol that we follow in our unit. This is to rule out if, you know, the maximum activity is at the junction of the lobe and the isthmus. So if there is no activity there, it's unlikely that you're left behind a disease on the other side. And well, while doing it, you look for recurrent, you look for external laryngeal nerve in all the cases. Now finally, what do you do for differentiated thyroid cancers? There is a lot of confusion whether to do less or to do more. It's a very good cancer, as I mentioned, so there are two schools of thought. Even if you don't do very aggressive work, it does reasonably well. But the flip side is, since it's a good cancer, might as well give it the best knock. So the tilt now is more towards the latter one, that is, get it out, so that the patient can live an absolutely normal life, and it's possible to live completely normally. The argument that comes against total thyroidectomy is that you're taking the whole gland out. How will the patient live on thyroxine forever? Well, let me assure you, in most cases, the remaining part of the gland, whatever it remains, is gradually going to be completely non-functional. There are patients coming with thyroid glands studded with nodules. There is hardly any active thyroid tissue. So they do become hypothyroid in the chain of the disease or the follow-up of the disease. The tragedy with thyroid disorders, especially thyroid cancers, is there are no prospective randomized controlled trials. There are none till date. So we are relying on retrospective data and the collective experience, anecdotal data. So we have no level 1 evidence. We have level 2, 3 evidence. So we have no choice but to go by it. Why is it so? We don't want to do it? No. The reason is the pattern of the disease is heterogeneous. It's widely spread and patients live for too long, so you can't follow them up for that long. Therefore, it's not feasible. Now I've just looked at the things in black here. In red is, of course, non-surgical controversies. The surgical controversies are if there is an incidentaloma and it's a papillary microcarcinoma. What is the practice? The practice varies from one to the other center. It will depend on how safely you do thyroid. There are benchmarking options of American College of Surgeons. As member of their society and as member of the academy of the college, there is a discussion on benchmarking. They benchmark a surgeon, they benchmark a center, they benchmark an institute. And benchmarking is a very honest projection of how many cases he has done, how safely has he done. Because it's very important in thyroid surgery not to be a tiger surgeon who will take out anything unless it is fixed to the operating table. Because the problem is, you will cause the morbidity which is lasting. It will cause for a disease which is otherwise manageable. So there is benchmarking in thyroid. For observation versus surgery in this, there is a controversy. Extent of primary surgical dissection, hemi and total, and need to do neck dissection. Well, this would interest all of you. This you've all been taught in your undergraduate days. Can surgery be tailored or can thyroid disorders be risk stratified? These are various criteria. Games, which is grade, age, metastasis, extension age. Ages, which is age, grade, extension age. I already talked to you about the age. Masses is surgical. Post-surgery, distant metastasis, age, completeness of dissection, invasion, and size. And of course, similarly, AMS and DAMS, which is what a lot of people follow today, DNA ploidy, age, metastasis, extension. You must have noticed one factor is constant, that is age. So important. When in doubt, we will try to advise total thyroidectomy. This is our protocol and it is shared by others too. Weber's et al. Were the ones who started with it. So we divide patients into 4 groups. Low risk patient, low risk tumor. Hemithyroidectomy can be done safely. The other extreme is high risk patient, high risk tumor, total thyroidectomy. And in between are intermediate risk, where there is low risk patient, high risk tumor, and high risk patient, low risk tumor. You can have the policy of your hospital, department, or your unit. We do total thyroidectomy in most of the cases because we do it safely. Now this is an article, if you're interested. We have discussed the Indian solutions to Indian problems. Your cases are different, unlike in the West. You can't reproduce that here, so you must have our own data. High risk group is 55 years and above, as I mentioned. I think I've covered this. Why total thyroidectomy? The points to support it. The first point is, we all read it in our Bayesian law. Most cancers are multicentric, especially papillary. It's there on both sides, so if you do it on one side only, you are leaving it there, it may come back. Well, this has been studied extensively, and opponents say that it is microcarcinoma, or what we call as laboratory cancer. You find it in the laboratory, but it doesn't become cancer in real sense. Can be left alone. But people argue. Distant metastasis. Now, why should it promote you to doing total thyroidectomy? The answer, friends, is it's a very important part for especially those who are practicing the medical side of it. If the patient has distant metastasis, surgery is a priority. Reason is, unless you remove the main gland, you cannot treat the metastasis with radioactive iodine. And we see lots of cases where the metastasis just melt and patients live for a reasonably long time, provided the gland is removed. If you don't remove the gland, the whole radioactive iodine will be taken by the gland itself. Thirdly, if you remove the whole gland, thyroglobulin can serve as a tumor marker because thyroglobulin is produced by the thyroid, the globules. So if you remove completely, the moment thyroglobulin rises, you know it is recurrence. Exception is 5 to 10% patients, especially with Hashimoto's, who have anti-thyroglobulin antibodies is destroyed. But there are issues. Of course, there is an anaplastic change. So whenever recurrence happens, I told you about 20-year survival, but there's a rider there. When it recurs, each time it becomes more aggressive. I'll share with you some pictures and you will find that interesting. Treat it as a benign condition, comes back with vengeance. Now the 3 bottom lines in red are important. If there are complications, if the surgeon can cause hypoparathyroidism or recurrent laryngeal nerve injury, if the rates are high, it is safer he does HEMI, so that at least the other side is saved. The patient can still be salvaged by radioactive iodine. Young versus old patients. Old patients, you have to look at the longevity. You can't do the same surgery for an 80-year-old. And high versus low volume center. I think the most important aspect here is the volume. If you're doing more of it, you'll do good of it and you'll do better job of the same. In favor of total thyroidectomy, these arguments are fairly acceptable. Well, these are the risks and these are the guidelines, so we can't be confused about it. Less than 1 centimeter, they say HEMI. 4 centimeter above total. 1 to 4, depends where you are. Look at the age of the patient. Look at the grade of the tumor, look at the overall multidisciplinary management approach. Now friends, no longer in today's era, including in India, not including rural areas, don't get into that thought process that it is different in one part and the other part. When the case goes to the court, I've gone for expert opinion for many cases where the argument was whether total was done wrongly. Patient has persistent hypoparathyroidism for 1 year. Patient is now claiming, so the judge is asking, he has done total, is that acceptable treatment? You want to save your colleague, so you would say, yes, it is an acceptable treatment. And it's an acceptable percentage of complication. What is acceptable percentage? 4 to 5%. Now, 4 to 5 would mean you've done 105, yes. So how many has he done? If he's done 3, and 1 has a problem, how do you defend it? So, very, very important to understand. That's why the drive home was 1 to 4 centimeters. This is the cutoff which slide stays in the mind. So you're happy with. This is again, we can treat it with hemithyroidectomy. Same article. Now the ultimate prognostic factors, as I'm coming towards the back end of it, patient related and tumor related. Patient related factors, therefore, age. Elderly, let's take it 55 and above. 55 and above is not elderly these days, but the cutoff is ATA guidelines is 55 now. They're trying to play safe. They're trying to push it to 60, 65 now. It was 45, mind you. Gender, male gender is a big risk. Ladies, when they get a milder one. Gentlemen, when they get it, it's aggressive. They get it less often, but they get a bad one. Tumor, grade, size, extent, and metastasis. A tumor that presents with metastasis to begin with is going to do badly. It's already shown its behavior. And surgeon. Who's doing it is crucial. So more than when to pick up the knife, who should pick up the knife? It's important. Can you do neck dissection? We do routinely central compartment dissection. I don't think I'll go there because that's not what the talk was about. It is done as a part of total thyroidectomy in my center. We do it routinely and we publish our results regularly. There is enough evidence in T3, T4 lesions because you can't go back in the same area. And central compartment, for the benefit of all, is pretracheal and paratracheal. Lymph nodes, they are the first echelon which is affected. So if the lateral nodes are positive, they're positive in 80% of the cases. If the central nodes are positive, 80% times you'll have lateral nodes also. So there is a role, and we do that routinely. Lateral neck dissection is done in all positive cases of neck nodes on ultrasound. With triple assessment, you will be able to pick up. And if you've done hemithyroidectomy and there's a remaining gland, you do completion thyroidectomy in all cases where you would have otherwise liked to do total, but you did not do because you didn't have the diagnosis, which means most of the cases. Now the question is, how do we do it? I did not have the intention of discussing it, but as Abhinav was saying, there would be a part which you should cater to, how to do it. It's an editorial I published in 2010 on the 10 important steps. Let's not call them the commandments, because commandments are the writing in stone. So they are flexible, shouldn't look like that. And thou shalt not operate by clock. No surgeon should operate by clock anyway. And I'm trying to comfort the physicians. If you hear of an anesthetist telling somebody that that surgeon is superior because he finishes his appendectomy in 15 minutes, beware of it. Because when it's your appendectomy, if he says, I'll finish it in 12 minutes, you say, no, please take your time, sir. I need no confusion. Surgeons operating by clock have no business to be in the neck. This is the position, make the right position, which is called rose position. You'll quickly find some pictures attractive, so I'll just take them through. And it's called rose position, it's reviving your MBBS, or also called barking dog position, also called caucus position. Neck extended with a sandbag here and a pillow here, Dunhill pillow we use. It exposes the neck nicely. You mark your incision, you make your incision, and platysma is cut a little higher than the skin. It gives a better scar. You lift it up, the flaps are raised in subclavius, plane up to hyoid bone and clavicle below. And we use these glove slings. I had seen at the Cocker Institute at Bern, they use the cardiac tapes so that there is no flap edema. We can't afford them, $150 each. So these are glove slings and they work as good. You can find an Indian solution for that. Stretchable, so you can actually open up the midline. You can. Some people ask you about strap muscles. You can cut them high, you can cut them low also now. Although the teaching is that ansa cervicalis enters below, so it's safer to cut them above. Go down to the carotid sheath. Always look for the external laryngeal nerve. Why is that important, friends? For those who sing and for those who teach, those who need the timbre and the pitch of the voice, external laryngeal nerve is as important as recurrent laryngeal nerve. You keep getting hammered about recurrent laryngeal nerve, but let me tell you, it can cost somebody's career. And you need to look for it. And if you don't see all these steps in any surgery, it's inadequate. That's why I was trying to highlight. And we call it a Nihas maneuver. We pull it down, open up the space. This is called the space of Reeves. Mandatory to do it each time. And to say that you've not seen it is not acceptable. And we have published our data. It's more than 60% times that you can see it. The record is 30%, 40%. If you do more often, you'll be able to cite it. This is a little write-up, tale of two nerves in thyroid surgery, which is important. Must look for both the nerves. That's recurrent laryngeal nerve. That's inferior thyroid artery. And you were also taught in your graduate days, tie superior thyroid artery as close to the pole as possible. Inferior thyroid artery as far away from the gland as possible. That's of course a wrong statement, no longer accepted. You don't tie close or far. We never tie inferior thyroid artery. Inferior thyroid artery supplies the parathyroids. It's in the era when we were not looking at that. We just ligate the capsular branches. So I'm repeating, never ligate inferior thyroid artery, just the capsular branches. And superior thyroid artery is dissected individually after finding the external laryngeal nerve. That's how the parathyroid looks, and that's recurrent. I'll quickly rush through. And there is a relationship with the inferior thyroid artery, which you can see here. We've got it on a sling, we can ligate these branches. That's recurrent laryngeal nerve. And you can see this caterpillar hump, and very easy to get it damaged. This is the most common site, ligament of Berry. Again, you're taught as it as a sling. So rather than that, it's a sheet. This is the most common site of damage. So we must take care. That's chirpy parathyroid, hemithyroid to be done. And a word about some anomalies which are commonly seen. So don't get alarmed if on ultrasound there is a report of a tubercle of Zucker candle. It is seen in 49% individuals of thyroid. And this is a friend or a foe of a surgeon. It's a friend of a surgeon, this anomaly. The moment you lift up, you see the recurrent laryngeal nerve and superior parathyroid sitting there. And this is one gland with pyramidal lobe and tubercle of Zucker candle. Both the anomalies are seen in 49 to 50%. Is it a friend or a foe of a thyroid surgeon? It is a friend. Now, I've covered this lymph node part, and when doing the central neck dissection, maybe I'll finish in 2 minutes. That's recurrent laryngeal nerve going up, and we dissect out the lymphatics alongside, and that's the gland seen again, and you can go laterally. This is vagus, this is interjugular, this is common carotid. We've got the central compartment clear, and finally, as you close it, you can use good subcuticular sutures, and whether you use drain or not is another question. We published a randomized control trial where we found that drains are the cause of drainage. So in thyroid surgeries where we don't do lymph node dissection, we don't drain anymore. We don't put any suction drain there. And this is one with ISRCT numbers. You can always pull in your data there. Ladies and gentlemen, to conclude, thyroid surgery is a specialized surgery. So the answer to the question is, thyroid surgery is most of the time treated by picking up the knife. But who should pick up? How much should he chop off? How should he do it? Is a $1 million question. So for me to say each time would be wrong. Most times and more often will be correct, but who should do it is more important. I'm always worried about people who are not scared when they ought to be. And whenever we do thyroid surgery, even after having done many, we would be extremely conscious of each structure. Anatomical dissection is the way. You must show each structure to the assistant so that it becomes a habit. You'll be surprised, friends. I did not train up when I was growing up to be a postgraduate to see parathyroids and recurrence. My mentor was of the old school. No, don't see, you will damage it. But as I go further, I train my residents to see it, because always is always wrong in surgery, never is never right. It has to change. It's true in life too, in medicine, everywhere. It changes. Next. So, today, they will cite it before I cite it, because we have shown them enough. So the moment they see, they will just there is a parathyroid. And friends, doubt is not a pleasant state, but certainty is a ridiculous one. Thank you all very much for patient listening. I'd like to once again thank the Allahabad Medical Association for this honor, and I salute Dr. Neogi on this day and remember him very fondly. Thank you very much.
Thank you, Professor Chintamani, for such a illuminating talk on this thyroid surgery. This is always a million-dollar question, that who should be doing this thyroid surgery, whether it is a general surgeon, an ENT surgeon, or an endocrine surgeon. The answer is anybody who is trained in that, doing that surgery can do it. And a lot of tools are now being used for doing surgery. See, in our field, we are used to microscope. We have started using a microscope for doing thyroid surgery and identifying the recurrent laryngeal nerve, the parathyroids, that becomes, and even the superior laryngeal nerve, that becomes very easy. Of course, it takes 15 to 20 minutes more time. I don't know what is your opinion about this endoscopic thyroid surgery. People are doing endoscopic thyroid surgery. We are not yet doing endoscopic thyroid surgery. But anyway, sir, your talk was very much good, and we have personally learned a lot from your talk, and thank you so much for.
Pleasure all mine, and I will answer your question, although Oration had that issue with questions. But since you mentioned my view on endoscopic thyroidectomy, I'm fresh from a conference day for yesterday from Pune, and there was a talk on endoscopic thyroidectomy. Look, anything that is minimal excess is very good. I use loops for doing parathyroid surgery more than for thyroid surgery, and I must confess that I see better without them, because I got so used to it over the years. But it's useful because you can spot the capsular vessels better. More than the nerves, I think parathyroids is where I would be keen. And other thing is to differentiate between parathyroids and the nodes. So there the loops are useful. Coming to the endoscopic thyroidectomy, I was traveling to UK for a conference, I think last year, before COVID started. And a Chinese surgeon sitting next to me. So we became friends as we were going. So I was working on my slides, so he asked me a question, you're a surgeon, etc., etc. He said, today the big surgeon is one who makes simple things more complicated. So, if I was to reach somewhere, most important thing is I reach there. Second is that I reach intact. And third thing is I don't hurt anybody as I reach there. As long as you can achieve all three, endoscopic thyroid surgery would be there, but it is limited to less than 3 centimeter nodules. And I don't think you can do a total thyroidectomy very effectively. And then you start from a different plane. Like I told you, everything has plus and minuses. So there are cases where you need that. With a good subcuticular suture, and nowadays with cyanoacrylate, there is no problem with the neck scar. I don't think any patient is asking. Most things are technology driven. Since you have, it's a hammer and nail syndrome. You have a scope, so must use it somewhere. You get a robot and you fix a hernia with it. So that's going too far. So it was meant for a pelvic surgery, APRs, skull-based surgery, tongue-based surgery. But then people are using since they have it, so to recover the cost. And suddenly a patient walks into my clinic and he says, it's a papillary carcinoma thyroid. He says, can you do it endoscopically? I said, even if I was able to do it, I won't do it in your case. So we have got to select cases and right cases, small nodules. I mentioned a colloid which is less than 2 centimeters, you don't need surgery anyway. So many times we invent, indications to suit a tool. But I have a lot of respect for those who do it very well, especially some Chinese and Korean surgeons do it. And through the oral approach, I've attempted it, but my job is mostly cancers. So I don't find neck dissection easy with that. Otherwise, any tool is good. It doesn't make it any different. And like they say, a fool with a tool is still a fool. If you can't do the right kind of a job, it won't really make a difference. Thank you.
Thank you, sir.
Thank you so much. I will now request Dr. Sujit Singh to please come on stage and honor the speaker, Professor Chintamani. I will also request Dr. Prabal Neogi and Dr. Neogi to please come on stage and honor the speaker. Thank you so much. I will now request Dr. Sujit Singh to please give away the certificates to the chairpersons. Professor S.C. Gupta sir, Professor Mangal Singh, Dr. Ashok Agarwal, Professor Shabi Ahmed. Thank you so much. I will now request the chairperson for the next session, Dr. Anil Kumar Agarwal sir, past president AMA and in charge AMA blood bank.